Hello, greetings from Zimbabwe. While we're waiting for everybody to get here, I'd like to say hi, I'm Mara, and I am here in Chicago. And if people in the chat, we're gonna ask everybody to keep themselves muted, except for our panelists, our fellow panelists, who you're gonna meet very soon. But if you could in the chat, just let us know where you're coming from. That would be really wonderful. As we're waiting for everybody to get here and come in from the waiting room. So we have Linos from Zimbabwe, Orlando, Boston, whoa, Calgary, Durango, I know where Durango is. Virginia, whoa, it's coming flat. Ooh, a lot of you guys, oh, Ontario, Florida, Canada, Texas, Washington, wow. Vancouver, Dallas. Wow.
Yeah.
What? Oh, somebody you're in a family med, oh, Leslie. Family Medicine Clinic, Denmark. Wow.
What are you trying to do?
So good to see you guys.
There are no room from.
So good to see all of you here. Okay. Good. We have a raised hand. Yes. Good. We're just going to give people just a couple more minutes to kind of make their way in. And we're going to get started. I'm going to let you all know what we're going to be doing here today, introduce you to our panelists, and we'll get started. All right. How are we doing on the waiting room? We're getting everybody coming on
Mara,
in?
this is Jamie.
Hi, Jamie.
Hi, everybody. I'm your online chat clinical host for today. This is Jamie Marich. So, Mara, do you want people to turn off their cameras or mute their lines? Because we're getting some confusion here with people not being muted.
Okay, yes. So if people could please mute themselves, yes, absolutely. And actually, that should have been the setting when people signed in. And if you could, please close your camera, because when we do get started, we would like the main screen to be the speakers. So that would be helpful as well.
And we can do that on our end, but it would be helpful if you can just take a moment to shut off your cameras. Thank you.
Yeah, it makes it a little bit easier. We are figuring out this technology here. I will share with you that last week I did a webinar and I experimented with Zoom webinar, and now we're experimenting with using Zoom meeting instead, and sort of figuring out the pros and cons of the way that the platform works for each kind of setting. So bear with us as we figure all of this out. There are actually not two Maras in this group, even though I have wanted to clone myself many times. I am actually not cloned here. We're just signed in twice because Chuck, who is my wonderful operations manager and Grand Vizier, is managing as me on the back end. And I think my lighting is not good. So give me just a second. I'm going to close some curtains and see if I can get some better lighting, and we're going to get started. All right.
And Chuck, if you're hearing me, this is Jamie. You could message me privately.
All right.
But the live stream is not on Facebook. So I don't know if there's something with your settings, but Chuck, you can message me privately on that. Thank you.
All right, let's see if that's any better. Okay, how's that, you guys? It's odd. All right, so welcome. I'm gonna start with some introductions and to let you all know what we're gonna be doing here today. And I don't understand why I look like a very friendly ghost, but a ghost nonetheless. All right. I am Dr. Mara Stein, and I am going to introduce our panelists and let you know what we're going to be doing here today. I am a clinical psychologist here in Chicago, and I come to you both as a therapist and a perinatal mental health specialist and a perinatal trauma specialist, an EMDR therapist, an EMDR consultant and trainer for the Institute for Creative Mindfulness, where I'm on faculty. And I also come to you as a NICU mom and mom of preemie twins who are almost 24. And really both of those roles are very much inform everything that I do clinically and in my teaching. And I come here today, and the idea for this webinar really came about for me because of the resonance that I was noticing and feeling with the impact of COVID-19 worldwide, and what it was evoking, certainly in me personally, and in what I was hearing in my clients and what I was hearing from colleagues and friends, what it was bringing up for people. And so I reached out to my colleagues and friends, Paul Miller and Katie O'Shea among them, and Jamie, to begin some conversation about this and about what we can begin to understand about it, how we can begin to support each other and our clients around it as we all move through this space, because this is not going to go away very quickly. We're going to need to figure out how to cope through this, and hopefully to come through it, not just to survive it, but hopefully to come through it with hopefully some more richness at the end, as we all hope that all of our clients who are experiencing trauma will as well. And so I asked Paul Miller and Katie O'Shea to join us on the team here, and I'm so honored and excited that they're both here. And so let me introduce them. So Paul Miller, who is here from Ireland, is a psychiatrist, an accredited EMDR Europe Trainer, an EMDR Institute facilitator, is a participating member of the Council of Scholars in the Future of EMDR Project for EMDRIA. He has served as chair of the training subcommittee rather, of the EMDR UK and Ireland Association, and introduced EMDR therapy to psychiatry in Northern Ireland's National Health Service. And in January 2011, he founded Mirabellis Health, which is a private psychiatrist-led clinic specializing in EMDR therapy. Professor Miller is a popular international speaker on topics including EMDR therapy for psychosis, and he is also currently visiting professor, Faculty of Life and Health Sciences in the School of Nursing, and is exploring the use of EMDR therapy with the Center for Maternal, Fetal, and Infant Research. And he is the author of the book EMDR Therapy for Schizophrenia and Other Psychosis, and he and I have been collaborating and working together around perinatal mental health quite a bit, and it's a pleasure to work with. Katie O'Shea is an EMDRIA approved consultant, and we all know Katie O'Shea's work, and a trauma recovery HAP senior facilitator, and having spent 40 years treating all ages and almost all diagnoses, 26 with EMDR, she attempts to support each person's healing potential in an efficient, effective, and empowering way. Katie has identified EMDR-friendly preparation methods, which allow clients to maximize their innate ability to unlearn what's no longer useful and to learn what is. Isn't that a beautiful way to express what we do? She originated the early trauma protocol for EMDR, making it possible to fully reprocess experiences held in implicit memory by focusing on time periods rather than specific experiences. Katie has presented at European, Canadian, and international EMDR conferences since 1997. So what we are going to do today is each of the three of us is going to share some of our thoughts as they are formulating so far on this larger topic of the impact of the COVID-19 pandemic in the area of perinatal mental health. And as we all know who work in this area, perinatal mental health is a vast, vast field. And so we're each going to reflect on a different part of it. And then we're going to spend a little bit of time commenting on each other's reflections, beginning some conversation. And we all, the three of us, really are quite aware that this is the beginning of a conversation, and that's what we hope it will be. And then at that point, we will open up the floor or the space, the cyberspace, to question and discussion. And I'm grateful to Jamie for curating the questions and allowing us to then be able to respond to those questions. And so I will begin opening things up, and then we will move to Paul and then to Katie. And so that is our program for today. So when I teach and talk about trauma, whether it's to my consultees, to my trainees, or to my clients, I talk about how our life experiences and our way of engaging with our life experiences is very much like weaving a tapestry. Some experiences are given to us. We're born with them. They just are what they are. Some of them we get to choose. Some of them we like. Some of them we don't like. Some of them we'd really like to get rid of. Some of them we'd like to cut right out of there. The thing of it is that we're weaving. No matter what, we're always weaving. So there isn't an option really to stop weaving. We're doing something with what we're given all the time. So whether we're given those silk threads and satin threads or cotton threads, the colors that we like, the colors we don't like, or if we're handed barbed wire, which I can tell you now from experience is really hard to work with, actually catches on absolutely everything. Snarls and it pulls and it's just really hard to work with. You gotta work with it. You just gotta work with it. What happens though is that when you're given all these really difficult materials to work with, sometimes what happens is you end up with snarls in your fabric. That's trauma. These knots, these snarls, these really difficult pieces, but you keep weaving, because you got to keep weaving. So what we're doing when we're doing our EMDR therapy or other neurologically based treatments is we're actually helping those snarls to unsnarl so that we can use adaptive information to reweave those same threads, because those threads are there, those experiences are there, to reweave them, to make them whole, to begin to step back and look at that weaving from a different perspective and no longer have those snarls that every time you pull on that same thread that's now down further, you get this reactivation, but no movement. So when I reflect on what can feel now like reactivation, I think about that weaving. So here we have a situation where there's danger. There's danger that is clear. There's danger that we cannot see, that we cannot really predict. We have some degree of prediction, but not complete. And so I think what I've observed is one of three kinds of things happen. Old stuff gets evoked. I can tell you personally that happened to me pretty early on in this journey of the last month or so, where I started certainly to feel like, man, this feels really familiar. The sitting, holding still, don't move, just wait, hold tight, felt a lot like bed rest to me. Felt like being put on bed rest real quick. I was put on bed rest without any warning, 24 weeks pregnant with twins. Don't move, no, you're not going to work. Oh, right, no working. That was the other thing. All of a sudden, you're not working. Can't go do your regular things. Job is gone. Your regular identity is gone. Your regular sense of self is gone. Your income is gone. Can't move, can't leave. I walked into the hospital in one season, left the hospital, it was a completely different season. It's really strange. It can evoke old stuff, but it also can cause new trauma. I mean, there is undoubtedly new trauma, present prong impact happening to people. There are losses, current losses of all kinds. There's the obvious, somebody getting sick, somebody dying, loss of income, loss of position, loss of people can lose a home, people can lose a family member. I mean, so many layers of what can be lost here. Losing your routines, kids losing a graduation ceremony. Let's think about perinatal stuff. Every reproductive technology cycle has been canceled. You're in the middle, you're planning stuff, forget about it, it's done. It's over. Tremendous loss, tremendous fear. What's going to happen? And similarly to perinatal trauma, you can do everything right and follow all the rules, and bad things can still happen. So there is so much resonance, so much familiar that can be evoked here in these situations, and then so much fear of the future. When will it be over? What will happen? For those of us who've had premature babies, medically fragile babies, medically complicated babies, it's not over when the baby's born. It's not over when the baby's discharged home. You know, this myth of, you know, oh, I'll take the baby home from the NICU. That, you know, the line is treat them like a normal baby, which, by the way, no NICU parent likes that. Don't ever say that. It's not over. There is always this uncertainty about the future. What's going to be? How's it going to be? Where is safety? Is there safety? Can there be? So we are in this soup of this. And so for some people, trauma is going to get unmetabolized trauma is going to be on fire again, because those embers are still there. They weren't put out. They weren't metabolized. And so you get this high activation, right? And you have that can't settle down kind of stuff. And I think we probably are seeing mixtures of this in ourselves and in other people. Both, you know, mixtures in terms of past, present, and future, and also the kinds of activation we're experiencing. But there's something else that I think is really important that I really want to highlight and leave you with here. And that is that there are going to be many people who we've worked with, and many of us as well, who have done quite a lot of our work, done quite a lot of trauma work, and who are also feeling a lot of this coming back. And it doesn't mean that we haven't done our trauma work. As we work with trauma, and again, I say this to my consultees and my clients and my students, it isn't that this stuff disappears. It isn't that it doesn't matter anymore. It's just that we're not reliving it anymore. And so what happens, go back to the tapestry. When that tangle has been untangled and rewoven, there's a pattern there. There's something there that we look at. And so if I go then back almost 24 years now and look back at that time in life, I have perspective. I have lived experience. I wouldn't go so far as to call it wisdom. You know, when I'm 80, maybe I could look back and learn something. But I have some perspective, but it feels like something. And you know what? It should feel like something. That was meaningful. That was the most important stuff in a person's life. That ought to feel meaningful. You know, when you're working hard in an infertility cycle to get pregnant, it means everything. When you're laying there on bed rest, trying to hold on to a pregnancy, to hold on to that, every day counts. They tell you that, and it's true. When you're sitting in a NICU bed, next to a bed, with the baby on a ventilator, wishing you could breathe for that child, and that's the only thing you can't do, the most meaningful thing in the world. That's what it means to be a parent. It's what it means to be protective. These are the most meaningful experiences. So to have those protective urges re-evoked is not necessarily a re-evocation of trauma. It can be a reawakening of the most deepest meaning making that we have connection to. And so it's important for us to hold both with ourselves and with our clients, to notice the parts that are activated in ways that interrupt our ability to function and stay connected, but also to notice the parts that keep us connected. Because there's a difference, for example, between reactive anger and irritability and righteous anger. And protective anger, not the same. And so this is kind of the work and the process. And it's all in the weaving. So I just sort of want to leave you with this piece. And I think we find this in relationship with each other as we talk it through with each other. And it's not simple, and it's not going to be just one thing, because of course this tapestry is filled with threads and it's complicated. And so let's let it be complicated. So with that, I would like to pass the baton to Paul and move on.
Yes. Okay. Yeah, I mean, I think one of the important things that we're listening here and what we're hearing Mara say is, again, what I've been finding that I've been saying to a lot of my clients and also supervisees. And that's, at the current moment, we all have hugely activated systems. It's very important to remember that as we're engaging with a client, that we have two windows of tolerance. And at the moment, perhaps more than at other times, we as clinicians have a very high likelihood of being potentially outside of our window of tolerance. So it reminds us the first thing is about self-care. And again, in the work that I would do with Sunny Brevetto in terms of first responders, one of the things that Sunny uses is the language of Mark Nickerson, which is a sense of that you are not broken. You are understandably disordered given the set of extreme circumstances. And so part of the thing here is about helping us to look and help people to understand that what we've really got is a situation where, instead of it being people not being able to trust their own bodies, not being able to feel like they can trust their own mind, that actually the message that we're giving to them is a message of, this is understandable. You're not crazy. You haven't lost your mind. You haven't lost your faculties. The reality is, at this stage, what we've got is something which is absolutely meaningful, because the system is being overwhelmed. Now, there's a neurobiology to that. Of course, we as EMDR clinicians use the language of the adaptive information processing system to help us to really be able to populate our understanding of the model and then how we implement it. And the AIP model does those three things. It explains pathology, and a lot of the work that we're going to be doing as clinicians at this time is explaining how a person's normal inborn system of information processing that we've been born and created with, how that's becoming overwhelmed with. And it's becoming overwhelmed because the sheer weight of what is happening around us. Now, this was the key change that took place in the nosology from a diagnostic point of view whenever we had PTSD introduced to the diagnostic lexicon. Because what it was saying was, instead of the model that we really had before that, which was a stress diathesis model, in other words, there's something which is an impairment in you or a deficiency in you that means that if these things happen, if you get a post-traumatic stress, that really it's because you weren't strong enough, you weren't clever enough, you had bad genes, your family are all a little bit, weak and unable to deal with strong and distressing material. And we see that in the language of the time. The Royal Air Force used to use the language of lacking moral fiber if people developed a psychological condition. So the blame was put right back at the person. And so for working in the perinatal period, we want to be able to communicate to the mothers and to the families that are going through these traumatic experiences that they aren't experiencing problems because of some deficiency, but that they're experiencing problems because it's an understandable reaction. Now, I think, Mara, I can share my screen, can I? I just want to quickly share for those of that you can see it. And again, we can organize for this to be put in. This is a picture of some research here by Ruth Lanius. It was completed way back in 2003. And what we see is a husband and wife who are in a severe road traffic collision. And this is a pretty well-cited study. I use it in all of my trainings, and I know a lot of people refer to it. But what we're seeing here is a functional MRI. Along the top line, for those of you who are able to see, we've got the husband's scans with the black and white and gray of brain structure, and then the yellows and oranges of brain activity. And then along the bottom, his wife's scan, exactly the same, black and white brain structure, color being brain activity. Both are being asked to do the same thing. They're reading out the narrative of what happened, which involved a road traffic collision and involved the death of a child, so a very severe trauma. Now, both have post-traumatic stress disorder, but we see the difference here that Mara was talking about. In the top, we see lots of nice activity in the brain centers that deal with language and memory processing. And effectively what the husband scan shows is remembering, okay? But if we look at his wife's scan, we see a very different picture, this little spot of activity at the back of her brain. And that's actually her visual cortex. So although she's reading the narrative of what happened, what we're actually seeing and what she is experiencing is a reliving of that trauma. So this is the difference between a relived and a remembered memory. If we've had a memory like this and a child has died and there's been a traumatic loss, it would be deeply, deeply abnormal for a person to not be able to understand that and have an emotional response to that. And so the reality is a normal system will show us distress and disorder as we're seeing here. But what's a deeply pathological state that we need to work on as EMDR clinicians is shifting it from reliving to remembering and then helping the person to process that. Now, in terms of that work happening, we're seeing it happen in a part of the brain called the anterior cingulate cortex. This little simplified diagram represents that, and it shows us and reminds us as EMDR clinicians the importance of the bilateral stimulation. So the dual attention is 1 foot in the present, 1 foot in the past. The bilateral stimulation is our eye movements or tapping. And what we see is that whenever we put in that bilateral stimulation, the signal goes into the ventral or front part of the anterior cingulate cortex, which is the affective or emotional component of the structure. It then has a knock-on effect on the dorsal part of the anterior cingulate cortex, which is the thinking part. And what we see is that the effect of that bilateral stimulation that we're doing as EMDR therapists is that it's down-regulating or switching off the emotional part and up-regulating the thinking part. So as we've seen reported in lots of different studies, we see that EMDR and the bilateral stimulation results in a distancing and noticing, a decreased emotional intensity, and an increased ability to think and rationalize and process. And there's a knock-on effect that we get a negative feedback. And so there's lots of good reason that we can say to our clients, look, you have a system that's got this, you can trust it, and whenever we do it, there's a way that you'll be able to experience a shift within the system. And I know Katie will probably talk a bit about Flash. There's ways that we can access memory networks without them needing to be within conscious thought. But likewise, whenever we get to trauma reprocessing in phases 3 to 7, that what we're actually seeing is an increased and improving integration. And the other piece that we see with that is the piece that relates to sleep. So in terms of, we used to talk a lot about, so Bob Stickgold's work initially looking at REM sleep and the importance of REM and REM processing. We see now from work that's been done with regards to Marco Pagani and his team having published work around the importance of what's happening within sleep-dependent memory processing. And we see that in slow wave sleep. And so where an average night of sleep, we see that happening maybe 3 to 5 times, within an EMDR reprocessing session with our clients, we're going to see the same thing happening between 25 to 30 times. And so this helps to explain why we get an increased speed and rapidity to clinical change that we're seeing within our clients. And again, there is an understandable neurobiology for why that's taking place. I always emphasize this when I teach about neurobiology, that it helps us to understand it, but it is not necessary to know this for us to have a treatment effect. Okay, so just bear that in mind. Lastly, in terms of just a little summary slide in terms of how one of my clients represented her processing, we can see just a little piece of art, and I know that many of you use art and such like with regards to your processing. And we see a situation here of a little cartoon strip drawn by the client that shows an awareness of the connection to the inner child who was traumatized. That traumatized part brings the broken heart to the adult part. They connect around that pain, which the adult part takes ownership of. And then we see here midway down through the cartoon, both characters now begin to have a face and an emotional tone being drawn in. And as the cartoon comes, we see connection between the parts, expression of emotion, and then integration of the parts through to resolution. So this represents what we've been talking about, the neurobiology, that we see a reprocessing, we see an engagement happening that allows integration within the system. And so the message that we can give really as clinicians working with mothers, working with families in the perinatal period, is that they can trust this underlying process. It exists, it's there, and it's something that they can relate with without, and basically trust themselves that this will do what it needs to do.
Wonderful, thank you. Katie. Get you unmuted.
Yes, I need to unmute my microphone. People who know me know I'm frequently saying creatures of habit we are, my Yoda saying. And I'm not, even though I use Zoom, I'm not in the habit of turning myself on and off automatically. And that's what actually that's what we need to take care of here. And what I'll learn, I'm going to get to this, but I want to give you the frame of reference first. Of what I've watched over my actually almost 50 years in the field, and looking at my own experience as well, because that was how I fully got in touch with the importance of perinatal experiences. I had chronic fatigue syndrome for 5 years, and nothing could get me over it. I knew what it came from. They glued down the carpet in my office, and I first had headaches, and then my whole body got involved. And I couldn't get rid of it until I spontaneously got back to my birth experience, which just felt like being scrunched up. And with EMDR, because nothing else would work to clear it up, then this overwhelming anxiety I'd never felt in my life, then a colleague said, that sounds like a birth experience, because I had no clue what all that was. And my mom was still alive, so I called her and said, was there anything else about my birth experience that was significant? And I was 55 at the time. Besides, I bent your tailbone. I think that's why I've been a pretty responsible person in my life. I was given responsibility from the beginning. But she said, well, they couldn't get your heartbeat for a while. So I think I had a near-death experience in my birth, which then later I spontaneously got asthma, and then this chronic fatigue where my body needed to know I needed to not be breathing in these fumes. And so the day after I did this processing and found out about that, I focused back on the carpet experience that I hadn't been able to clear up for 5 years since I'd even been trained in EMDR, and immediately had this image of 2 more inches of lung, and my back straightened up, and I realized my body had been trying to protect me through all this time from inhaling the fumes. And I wouldn't quit work because I had a foster care program of with 12 families I was responsible for, and kids, and so I kept going to the office. And so I then was completely over my chronic fatigue, and spontaneously then saw the Vietnam era veterans that I was working with. When we got that cleared up, then it went back, if they were still feeling some distress, it went back to the very early life experiences. And then over the years, both my colleague Sandra Paulson, who also teaches the early trauma protocol now, had began to realize that we had to get back to the intergenerational stuff. And I've worked with lots and lots of veterans and limited my practice primarily to clinicians for the last 10 years, because I haven't found anybody who doesn't need a whole life review, which is the research I'm starting for a protocol that hopefully every one of us will have access to make sure we don't have any old stuff that, and the way I've begun to describe it, I love your tapestry explanation, Mara. And that goes back to one that we've used for a long time, but I like your expansions. That I've been calling this updating our programs. That I think that's a concept that we can get, because my iPhone is updating itself every other day, I think. And I think that's actually something we should pay attention to, that we're probably going to need to do the same thing if we actually accept that we are in fact compelled to learn from every difficult, traumatic, stressful, whatever experience, however we categorize those. And particularly from what got passed down epigenetically, just like we breed horses and dogs for their capabilities because they get passed on, same thing happens to us. And that's not only talents, but unreviewed, unupdated experiences. And that if something activates that memory, then we may have some pruning to do. I'm using the tree of life as our symbol, because in those roots, if we haven't made sure everything's okay, it's going to affect the whole tree, not just a branch here or there. And I think that's particularly what's happening with this COVID-19 focus, that we really are realizing to, in my processing of my sudden seeming like I might have symptoms when I couldn't imagine how I'd been exposed. And went, okay, I got to see what this is about. So what I want to emphasize here is everybody needs to fully focus on this danger and not just kind of have it up and operating continually, well, like we seem to have with our, if you turn on the news at any point in time during the day or night, somebody's reporting on it, on the pandemic. And so we need to fully focus on it and see where it goes. Whether that's our, in this lifetime or a past kind of experience. And that includes our, that includes all the people involved, and particularly when we're dealing, my greatest concern at the moment is people who are expecting or who have just had a little one and we don't have hospitals available, and knowing that kids can't feel okay unless parents feel okay. So this means, and looking at and working with healthcare workers, if they're not okay, then they can't help the families, in the NICU, that sort of thing. So this means everybody needs to fully focus on this and see where it goes to. And we've certainly all found, with all the trainings I've had, I found EMDR is the most efficient, effective, and empowering. So that's why I'm still doing it and not retired at age 74. And sharing what I've had the opportunity to learn in all these years, that we really need, and working with lots of veterans and lots of first responders and healthcare workers, that we all need to review these things and unlearn what we don't need that create those tangles that's stuck in there, and learn whatever we do from this. How can we be prepared? And we actually have wonderful colleagues in the Netherlands who are focusing on future anticipated concerns first, even before looking at the old ones, because we've realized just how compelled we are to prepare for. Our Boy Scouts in the States, be prepared is the motto, and they knew what was going on. And the other thing that I think is really important for us to learn is there are some things we can do ourselves. We teach the butterfly hug or move your eyes back and forth to help yourself, but sometimes we can't do it alone. And even I can't do it alone when there's life threat involved. Our body knows that as mammals, we don't survive without each other. And so we either need to have someone to share it with, as I've said for many years, sometimes we need to hold each other and cry, but that makes all the difference. And guys, I worked with lots of guys, you cry too. I don't find any difference in those biological emotional circuits that we all have in our right hemisphere that's connecting with what we've already learned in the left at night during that dream REM sleep. Connect what we need to learn with what we've already learned. And that's why our bilateral stimulation speeds up the process. We're just doing what our being, mind, body, spirit, is made to do. And that the emotion needs to reach the level of importance of the event or it won't fall away. But if we let it, if we feel what we need to feel, strong as it needs to be, as long as it needs to be, it only lasts 90 seconds. And I've been watching this, folks, since the early 90s with my Vietnam era vets, particularly, and everybody else since then. So we don't need to be afraid of these emotions. They're there to say, wait a minute, you haven't learned everything you needed to learn. Get it figured out. And so welcome it, feel it, give it our full attention, and hopefully speed it up. But know that sometimes we also need a specialist, which is, what we all are. But it may be even, if we take a look at, at the NICU, and our healthcare workers have cared for themselves and are being taken care of, they can be that specialist to help the person maybe understand, a mom or a dad or whomever, understand what that baby's going through and what they can do to prepare, or help, or, what we might not be able to do, because we don't want to waste time on what we can't do. So we got to acknowledge that and then figure out, what can I do? And do all that we can, which is why Mara said, we got to do this webinar, right? Yeah. So let me quickly tell you, I want to tell you what happened when I focused on this sore throat I was getting, just as an example of how we really need to know that we can trust ourselves to have this information, the adaptive information processing, as Paul mentioned, the AIP model, that we have this information many times inside that we didn't even know was there. So what happened to me when I felt this sore throat, and I didn't have a thermometer handy. I'm now carrying it everywhere I go. And I didn't feel like I had a fever, but I thought, wow, this sore throat, and I'm feeling really spacey, like I can't even hardly stand up. What the heck? So when I focused it in, it went immediately to my birth grandmother dying in the 1918 flu epidemic, which I had known about, and I went, oh yeah, this this pandemic has some real, even more relevance for me. My mom was 2 years old and was then adopted by her aunt and uncle and raised wonderfully by them, and we don't know, but I think maybe she actually found her mom dead, and that she was, and I've heard she was pregnant, they think, with a second child, and I was the second child in my family, and think that that had to do with me not coming out until after my due date, hence bending my mom's tailbone, and excuse me, also I was born during, or 5 days before the end of the Second World War, and my dad was building planes and everybody was oriented to war, that I didn't want to come into this world. So the thought, I'm going to die, came to my mind as I'm processing this. And then 1350, 1350, 1350, 1350. And I thought, what the heck is this number? So I Googled 1350 and found out that the Black Plague wiped out France, England, Scotland, part of Ireland, where both my grandfathers are from, between 1348 and 1350. And I don't remember ever reading anything about that, but somehow my being had connected it up. And then as I read the information about it, it said that many people in Ireland were able to get into the hills and didn't die in it at the same level everyone else was. However, most of Kilkenny was wiped out. That just happens to be where my O'Shea ancestors are from. So we may be able to get, and then what came was, as I focused back on this after I got the information, I went, okay, body, are you're thinking you're going to go in this pandemic and make sure we know what we can do. And so what I saw was the people back then, because it said in the 1348 to 50, they were throwing their poop out the window and drinking out of the contaminated Thames River in England. And both my grandmothers were English, so I got that too. And they didn't know, they didn't have the conveniences or the capability that we have now to protect ourselves and how to make sure that we're not just perpetuating this virus and all that we can do. But I needed to have images of them doing, getting bathrooms and all those things so that they didn't, weren't locked into that. So that's the reason that I typically call this, what we're doing is updating these programs, because apparently part of my body was stuck in, you can't do anything about this. You're helpless. And got to, I am alive, I am capable, I can wash stuff and be capable of handling things, and know that how important it is for each of us to make sure we're not in distress. And that what we've done is move this from feeling to fact. I text that, and the example I usually give for people is we want this to be like what we need to do when we're driving is we have reviewed the dangers on the highway. Driving can be deadly, folks, but we don't want to be in distress. We want to know that and be relaxed and ready, paying attention to whatever we can do to protect ourselves, and know that we don't know what's going to happen in 3.5 seconds. That's a number I often use and teach people, that we need to make sure what we haven't reviewed is set aside, our corpus callosum, keeping it over there till we can give it full focus and connect up. And then remind our body it's okay to feel safe when I am safe. And as we were reviewing, is the word I use, the danger that we all felt about this with our intensive healing group night before last, all of a sudden the whole house started shaking and we were in the midst of an earthquake. Confirming that all we have is safety in the moment, folks. So we want to make sure we've reviewed the old stuff and anything, potential or possibly dangerous. We've learned all we can and are prepared as we can be. And then also having a wonderful time with each other and sharing what we know, so that all of us, and that's the good thing. As we've charted how this whole process works automatically, I've said that the final stage is gratitude for what was gained. And I'm not only grateful for having this extra opportunity to connect with my wonderful colleagues and share what we know with all of you, but that awful as this is, that the whole world is affected, my hope is it really is going to help us all come together and realize we are all here together. And we need to be helping each other, and enough of that discrimination crap. Because we all have these wonderful beings, bodies, and capabilities. And what we need, and we have a care circuit. We're made to take care of each other. Let's just do it.
Absolutely.
So thank you, Mara.
Thank you. Yeah, thank you so much. I want to give everybody, each of us an opportunity to comment sort of on what has come up for each of us, listening to each other, and then open up the floor for questions. I just have to say that listening to both of you, what keeps coming up for me is the power of connection and integration, and that they go together. And that as we connect with one another, it facilitates integration. And Katie, as you were talking about, this stuff that you are aware of coming up in your system, I was thinking about what was coming up for me a couple of weeks ago, and I kept saying, I want to write a blog post, and it's refusing to be a blog post. It keeps wanting to be this thing that is going to be written in second person. And it wants to be, I thought it was going to be a story. I'm like, it is not being a blog post. It is refused. It was this, and I couldn't do anything else until this thing it was so clear. And so finally, I just let it be what it was going to be. And in fact, Jamie named it for me. It was actually a poem of sorts. And I wrote it. And then I did some digital art on it, which was actually layered. And it was after the fact that I realized that was a processing experience. And that in doing it, I did not do it in isolation. And I feel so much gratitude to my friends and colleagues who are friends who said to me, basically, don't fight this thing that's emerging from you. Let it be itself. All right. Oh yeah, right. Let it be itself. let this thing process out in whatever forms it's gonna process out. Help me hold it and do it. And I couldn't have done it without it, and I needed to. And then it really, and it put together some pieces. Some pieces had been obvious, and other pieces had not been.
Right.
And so we have to do this in community, and this is in fact a community experience. And when you think about perinatal mental health, I always teach Winnicott's famous comment: there is no such thing as a baby. A baby only exists in relation. And so I have a slide. It says there is no such thing as a baby, and then the slide shifts and it says there's no such thing as a parent. There's also no parent without connection, right? We only exist in these family relationships because they are relationships. And so it just emphasizes all of that for me. So thank you for highlighting all of that. You cannot emphasize it too much. Paul, do you have some things to add?
Yeah, no, definitely. I mean, I was just thinking there that some of the questions being asked with regards to the you're talking about connection there in the system. And I think we talked about how there's, I think Uri Bergman talks about this sense of that we form this dyadic system that's an energy system between the therapist and the client. But actually, whenever we're looking and working in the perinatal period, actually, instead of the two windows of tolerance we've been talking about in terms of therapist and client, we actually maybe have three or more, because we have also the windows of tolerance with regards to the system of the children. And then again, the partner can be a part of that too, depending on what areas we're working on.
Regulational systems.
Yeah, so there's we know that from work with children that how well children respond to trauma is intimately related to how well their parents do, and a key part of that is about self-regulation. In the past, we wondered about it, and that when Melanie Klein was talking about her sort of energetic transfer, it all sounded a bit strange. But now we have the benefit of the awareness of the role of mirror neurons. Mm-hmm. And so we know that those mirror neurons are working in terms of really what helps to create unity.
Right. Right, very much. Yeah, fascinating.
Well,
so I think in terms
also,
of... Sorry, go ahead.
I was just going to emphasize too, Stephen Porges's work showing us that we not only have our sympathetic, parasympathetic safety systems, but our social engagement, that biologically we are monitoring each other for safety all the time, that we really are dependent on each other. We don't survive. And I look around, like at the studies of aging, as I'm entering that category, that people alone have way more troubles on every level: physical, emotional, blah, 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 when we don't have contact with others. Yeah.
Yeah, totally. And I mean, and I think the key thing that you were hitting upon there is that whole role that we're now seeing in terms of epigenetics, where the stress that's present and influencing actually, if we look at the work from Rachel Yehuda, we see that in terms of children of Holocaust survivors, that we're seeing epigenetic risk coming down both in the maternal and the paternal lines independently. And so, it is very important that we understand why, what's been happening. But equally, as you've been alluding to, Katie, not just the generation before, but these epigenetic switches can have been passed on really from many generations.
Way back.
Way back. But the benefit is that as we work on those systems now, the way that epigenetically things are created, basically each of us within each single one of our cells has a genetic code to make one of us. So, each of Katie, each of Mara, each of me, we have this sort of 6 feet of linear DNA if we joined it line to line inside every single cell. So how do we package that? It's a bit of an issue when we think about even the concept of it, but it's rolled up around these little spools, which allows it to become very densely packed, and then that's how it fits in. But the key thing is that with epigenetics, and what we're seeing is that only the part that's exposed gets encoded and then produced into protein. But this is why the stress that can be an influence can cause rolling and unrolling, so different things become exposed, and literally we then have different proteins being manifested. So the example that that's been given is some, for example, of the agouti gene in mice, that with stress or poor parenting, so a poor mouse mother is no licking or grooming, and what you end up with is a fat, obese white mouse. But with good parental licking and grooming from the mouse mother, you end up with a healthy brown mouse, but exactly the same genetic material. And this is important for us in the mental health field, because for a long time, and I started off in psychiatric genetic epidemiology, looking at the genetic epidemiology of schizophrenia. And what we see is we're being told that these conditions are extremely biological. But actually what we realize now and we understand is that there's a huge impact from environment, and that change that's happening is also being passed intergenerationally. And that's important for us to remember. And when we work with parents, and the work that we're involved in Ulster University, being again led by Professor Marlene Sinclair, who I know is on the call, the reality is when we look at that sort of work, we're interested in that whole range of perinatal health that you've talked about, Mara, coming to infertility, the pregnancy itself, how that follows through, and then birth trauma, and then subsequently in that period, because there are different aspects that are affecting. But what I'm interested in is then ultimately we're going to be interested in bonding, attachment. We see the work then of ACEs and the importance of Folletti's work. And these are very important things to look at, because we're now beginning to understand how they have a real role. Katie, you mentioned about Stephen Porges there, and helping people to understand that there's a meaning to why people are reacting as they do. Because as Stephen Porges talks about, we drop back from the more modern system to the older to the oldest. And so at the minute, if we use the example of COVID-19, a mum who's a bit anxious and stressed, who has already dropped from social engagement and dropped into the sort of fight or flight system. The problem is if that mum gets even more pressured with COVID-19, and now maybe something is happening in the perinatal period, maybe she's going to have to think about, is this an emergency section? Do I need forceps? The problem is dropping back again means that she's dropping back into a passive defense system, which is your dorsal vagal. And then that's a big problem for us as trauma therapists, because that's where we see the seeds being sown for a lot of difficulties.
Right, and we're seeing, and we're going to move to questions in just a second now, and we're seeing, as we know, lots of implications because of COVID-19 in birthing right now, in terms of restrictions around who can come into the delivery room, and recommendations or suggestions that infants, newborns should be separated from moms if mom is testing positive for COVID-19, symptomatic or not. So let's open the floor now to questions. What have we got? Jamie,
Mara, I just wanted to add one thing before we go to questions.
Sure.
That I've had numerous experiences with moms before a baby was born, where when we reviewed these past experiences, either their own difficulties in pregnancy or in their own birth or whatever way back, that then the birth can be quick and easy, and even with no pain.
Yeah.
And so
our potential
for really attending to these dangers and then preparing for the future is huge. So
yes,
all the work that you're doing, and you know, all of us educating.
And one of the things that I emphasize a lot is that all of this work, and I would say, Katie, all of the work, the pre-verbal work and the life review work, it's all primary prevention. This is all primary prevention work. When I went to apply for the special interest group for EMDR, and the little line on the application says, "Who is this group for?" In all caps, I said, "Everybody." Anyway, so questions.
Mara, this is Jamie. I just want to let participants know that they could use the question and answer feature to directly ask questions, although I'm kind of siphoning out some that have come through on chat.
Right.
One that I know I would like to hear you all directly speak to as well is a question I get from some clients who is due to give birth. Is my baby going to be safe? What if I become ill? So in your experience, how would you address that with the client?
So you're talking about in this current context?
That's what the question's looking like, yeah.
Yeah. Yeah. So, I mean, I can tell you what I'm seeing and what I'm reading, and what I would say to moms. This is a big topic of conversation amongst maternal infant mental health specialists right now. Number one, they're not seeing any vertical transmission of COVID-19, meaning they're not seeing any transmission through the placenta, from an infected mom to an unborn baby, as of yet. That's number one. Number two, they're seeing virtually no infection in infants. Now, I know there have been isolated reports of this, although it's still unclear actually what has happened with those reports of infants dying who have tested positive. There's a lot of murkiness around those. What I always find interesting is they make news because they're unusual, actually. Now, there's no guarantees here. This is a novel virus, and certainly we can't make medical recommendations to people. But we do know what separation can do. And we do know certain kinds of very concrete things that we can do in the present moment that is protective against transferring a virus if someone has a virus. So what I've said to clients who are worried about this is to have those conversations with their physicians about here and now, present-oriented ways to take action to protect oneself and one's child in ways that are fact-based, based on the information that one has in the present moment. Because that's all the information that you have. And that includes information about the potential risks to separation from a newborn, for example. Yeah, Katie, let me unmute you here.
Mute myself too.
There you go.
I just wanted to add that I'm getting the Monday presentation by the Pre and Perinatal Association, APA, and last Monday they had a presentation by doctors and NICU people about the differences they've seen if they do have to separate a mom and baby now, which used to be standard operating procedure for most of us, and also why I think so many people have unreviewed early life trauma, but that when the baby is told, I need to be, mommy's not feeling well, you need to be safe, whatever, that their receptive language is really much greater than most people have understood. And that we really can manage even those difficult situations. And then what I've taught for ages is that when you hold a baby, we are compulsively driven to do this. And that's bilateral stimulation. And if we then tell the story to the baby about, oh, it was so scary when I couldn't be with you, and acknowledge the feelings and release them, then it can be totally updated for the child in the moment.
And we mustn't forget the other parent too.
Yeah, well, right. Yes, and the other parent, and it was one of our wonderful colleagues in London who I first learned that daddy's bodies are made to warm the baby right after the delivery while the mom delivers the placenta. And that we should be, we need to have dads present. And I don't know if that operates if they're same gender. So we should check on that. if it just
Always good
happens
to have a partner present.
as we're supposed to.
Questions here. Quite a few more questions here.
Sure.
So I wanted to keep it going if
Yep.
that's okay. This one came through. How do we maximize support when parents are being isolated in the hospital at home and can't get practical help with breaks, care of the baby so parents can sleep, and those types of issues?
How do you maximize
You
emotional
just
help?
ask it again.
Yes, it's basically how do you maximize support, especially when isolation is a factor in this current reality?
I think the first thing is to help the person to think outside of what maybe they have in terms of their normal and immediate resources. Part of the difficulty is that whenever a person is put under stress, one of the major problems we see is a difficulty with idea revision. And so if my initial idea that strikes me is, my partner can't be here, I'm stuck by myself, I can't ask for anybody to bring something because they're all on lockdown. All of these thoughts that are coming in that normally a person would be able to sort of knock off and throw away and then resolve it and look at things in a different way, that idea revision is impaired because of the difficulty with bringing the information in. So helping, first of all, to be able to teach those grounding, early intervention, self-regulatory tools such as the butterfly hug. Somebody was asking about other phase 2 things that I would use. So again, in complex trauma, teaching people and giving them the option to use something like heart math, where they'd be able to, again, using breathing to regulate. And so these are tools that we give the parents in their kit bag, because we're talking about mums and dads and birthing partners and such like. The reality is that the affective tone that's going on in that system is important. And so if you have an agitated, distressed parent, they're never going to help to calm and comfort the child. And what we've got to remember is doing something like the rocking or the tapping or breath work, we're increasing parasympathetic tone. And that's exactly what we need. If we're looking at that anxiety being actually at the time of the birth's a deeply parasympathetic activity. So these are all things that we can be doing in a very practical way. But the key thing is that then that increased parasympathetic tone keeps the person in their window of tolerance and allows for idea revision. And then really for us as therapists or people who are walking alongside the family, we can say things like, well, what other options might we have here? Well, actually, look, this hospital has people who can come in and hold the child, the sort of grandparent, wise elder role, that somebody can come in and do that comforting role that may or may not be available. But this is where we as clinicians need to have an important voice, because the risk is everybody shouting virus, COVID-19, COVID-19. We need to remind people that if we don't take care and help in terms of self-regulation now, that we will be reaping the whirlwind down the line, and that actually taking time to have things that help with regards to emotional regulation in the here and now for mum, for dad, for birthing partner, that actually is something which will help in terms of bonding, attachment, self-regulation. We've seen it in regards to phobia and fear around breastfeeding, and again, how the impact that can have. And think about the impact that has on attachment for the child further on down, wherever there's been difficulty and impairment with that. So helping with idea revision and helping window of tolerance concepts, I think it's a great sort of thinking through things from sort of first principles, and I don't think you'll go too far wrong.
So another question theme that's been coming up is about resourcing from an EMDR perspective, specifically in phase 2, but how that might translate over to providing resources for mothers in the home environment or families in the home environment. So it seems like a lot of people, and Paul, I know you passed something along that I shared with the group privately. There's kind of a wanting to know, what are your favorite resourcing strategies, either that you would use in a phase 2 EMDR context or that you might give people to use at home. And so I'll let you chew on that. And then an interesting specific client question came through. I have a client with a horrendous trauma, has done a lot of work for the last 2 years. She's due to have a baby in 3 weeks. She will have a home delivery. I would like to know if there are any recommendations in terms of resourcing her. So that's a more specific question, but the larger question here is around resourcing and your favorite strategies.
Well, I suppose I already said about heart math is a big one I use with the complex trauma people, because what I teach people is that we have, again, an inborn system that I'm helping them to feel secure about, that they can trust, and that how the breath is a way that we can sort of use our conscious system linking into our unconscious system. And so heart math would be a sort of go-to for me. The other one I do is resource installation, which I call the fishing jacket. So one of those jackets and vests that has all the different pockets. Mm-hmm. And what we'll do is I'll get the person to visualize moments and times in their past where they specifically connect to a resource. I get them then to imagine that appears on a big screen in front of them. We enrich the feeling. Let's say it was I'm strong or I'm decisive. Then that they press an imaginary button, and then this little icon drops down into a basket below the screen, and then they take that little sort of symbol that represents I'm strong, and they put it into their pocket. And I'll get them to do a whole range of sort of what they feel they need to be able to address the issue. And then when we're getting ready to go in and work on the reprocessing, I have them tap their pockets with regards to those different imaginal pieces. I'm strong, I'm confident, I'm brave. And then they use that as a way to really sort of prime themselves going in.
Mm-hmm. Yeah, I love those. I like to, I do something similar, Paul. But I'm a little more the fantasy magic style. So, we might connect to fictional characters, superheroes, natural objects, animals, fictional or otherwise, that represent or connect to certain qualities, or magical objects that they can then have in a pack, in a bag that they can then draw out. I always ask what people like to read, what they like to watch, what they consume in terms of fiction. And I'm always very excited if they like to read sci-fi and fantasy, because then I know my work's going to be really much easier. Not just because we speak the same language, but because they'll go right for the metaphor. it'll go. So like to install those sorts of things. And in terms of helping with this particular sort of birth, the birth situation, kind of coming into the here and now around what does this mom need? What would help her to feel present oriented in the here and now, to make this birth feel different and distinct in time from the prior birth? Internal resources, external resources, physical kinds of things that might help her to stay present in the moment, things that she knows about herself that she's acquired through the work that you've done with her over the last several years in particular, can also be very helpful in orienting, in addition to the resource pack. Does she need a magical screen to make the past for that moment? Does she have a good solid container for that past stuff, for even for physical sensation, for example? So some things like that.
And I think as a part of that sort of co-regulated system we have, then, got to also remember where people have then the work that Phyllis Klaus has been hugely involved in with her late husband, in terms of doulas and natural birthing partners, and how, again, there may be some systems, belief systems and structures and metaphor that are coming in that actually you really link into that. For some people it may be a symbolic sort of fantasy magical, but actually for some people they maybe are coming from a very strong faith-based system, or within that sort of natural birthing system and doula structure. That's a very rich resource for people as well.
Yeah. And it was Phyllis's work with physical problems that she asked, what does that part of you look like now, and what would it look like healed, and found that if you can see it healed, the body can heal without any outside intervention, that I learned from her in 1996 and have used ever since and seen amazing things. But it was that belief in the imagery that brought me to the updating the circuits concept of updating our emotional circuits. What does this emotion look like now? What would it look like?
Yeah.
And then just adding the right left stimulation until it stops changing, and then it's available but not activated unless you need it. So that's my primary resource that I teach, because those are all the emotions are part of ourselves, and they can be stuck in time, and that can be done without you don't feel any emotion while you're doing it. So that those emotional circuits are caught up and up to date. Then they don't tend to over respond or get shut down. And even if one of the other aspects I've found, people who had significant early life trauma, which I expand, as you said, beyond sometimes the first year to 3 years to 5 to 7, when we're still semi-automatic learners, they have trouble with imagination. So I found they had difficulty, with the other kinds of concepts that do work for some people. So that's great and good to have several options available. But what comes to mind as you ask, what does fear look like? And so people can think of something and still do that kind of updating, even if you can't see the program. But it was Phyllis Klaus's focus, and then following all that. I was wishing I'm not in my office. I have their book that I would whip out and all that for you.
There's another very practical question that's coming through. So with the idea of parents being kind of stuck at home, because often in more regular circumstances, they can ask others to help with the children, with house cleaning, with tasks, with babysitting, but now with social distancing and a lot of contexts, that's frowned upon. So what would you, I'm just tossing that out at you, all the experts, to see what you would say.
So I've had these conversations for the last several weeks with my clients. Simplify. So, people, it's an opportunity, I think, also for people to really have to stop and really look at where's the urgency coming from around whatever the urgency is. So look, there are certain things that are urgent, but there are a whole lot of things that are not. I think that probably the hardest thing is really when there are lots of kids and those kids have needs, and you're really working to manage those needs. I think, really the struggle is around expectations of what's good enough. What makes me a good enough parent? What's good enough for these kids? Am I failing them in some way? Am I ruining them forever? Have I, is this, I have parent moms saying things like, damaging her is gonna, be forever, and, so much fear about what's gonna happen. And so, really pulling back, more compassion, more kindness, and recognizing our resilience, our kids' resilience. We don't need as much as we think. We survive much better than we think. Than if we can stay tuned in, if we can just stay kind, bring in the humor, we survive much better than we expect.
Adding fun into the schedule, break time. Someone said, recreate is the same word as recreate. I said, yes, that's a good thing to pay attention. We really are recreating ourselves. When we feel the pleasurable emotions, we are taking energy in. The protective ones is energy going out. So we need to make sure that we are experiencing those pleasurable emotions, fun, care, love.
And it's such a sign of not being in that, those more traumatized, vigilant states, when you can access humor, when you can access fun, that's your signal that you've downregulated and you're in that state. So to try to know that.
Because you're taking on again what we were talking about with Stephen Porges's polyvagal theory, that the humor is often something which is deeply, connected with that sense of social engagement.
Yeah.
And I think sometimes just helping people to see that. Again, we were talking about this the other day in terms of Rolf Carrier's quote, "Don't let the best be the enemy of the good," and helping parents to know that they don't have to be a perfect parent because no such thing exists. And so giving people permission, first of all, not to be perfect. I know from some people around me at this stage in my life, I'm seeing people approaching 3 weeks to a delivery and what they've been able to do at this stage, because the message is again about, for us here, certainly in Northern Ireland, is the sort of, shelter in place, only go out for certain things, but the limitation is in terms of household. And so some people have been anxious about that sense of being isolated, but for one couple, they've returned to be with one set of grandparents, and that's how they're trying to manage, and they've created a system. And I think that can and may work for some people. If you find a situation where you have mom and her partner and the child in that sort of unit, and they're sort of quarantined together, I think simple things like, we've talked about the role of fun, but be explicit about that there's going to be work and stuff to be done around baby, but there's other stuff that can be fun stuff, and to make those two things distinct, and to equally give each other permission to say, you don't have to be with me the whole time, because part of this is I'm here to give you permission to go and rest. And I think sometimes the language of, a battery, or the energy language, or even just the window of tolerance language, even good things can stress us out and can overwhelm us. And so needing time to sort of unplug, relax, that's good, even if we're unplugging from people that we love and care about.
Yes. Great.
Yeah, and the timing thing, creating a kind of a schedule, that's what I learned to validate that I learned that we could just focus on early time periods and the body would remember, and then learned that Chris Bruin in the UK has concluded the two primary ways we store memory are by time and location. And so part of this disruption, I think, for people is not having a schedule. And so to create that, then set aside, fun time, work time, reflection time, those kinds of things, all, that helps to deal with it.
We know from doing those things, Katie, that one of the things that healthy functional relationships do is that they boost our functional immunity. And so the reality is, my big concern is by withdrawing and separating mom and child, that I would be concerned that there could be potential impact in a negative way on the immunity of the child. And so I think we do have to be mindful of that, because actually functioning interdependent relationships do an awful lot with regards to how functional our immunity works. And if we're not getting that right, then there is a risk that we actually are causing increased potential problems.
Yeah.
Well, and knowing that we can update even in little babies, that if we have those experiences, as we go back and review them, I mean, I know that my body is functioning way better than any other 74-year-old I know. I just got results from my blood tests. And it's because I have reviewed all this and had immunity issues that we can fix even if it happens. So I think that's a really important thing for particularly parents that are going through this time in the midst of COVID-19, bringing in a baby into this world.
Yeah, and I think, we're just about out of time. There's still so much to talk about, which I think is so understandable. And I thank all of you for your questions and conversation. I'm struck by, again, that the key seems to be compassion, connection, and embracing our imperfection. that the imperfection doesn't ruin anything. The messiness, the imperfection, you know, this is our humanness. It's our humanity, and it's a feature, not a bug. So rather than being afraid of it, everything that we can do to support making space for it and embracing it, creating humor around it, experiencing and being with, allows it to process and not get calcified and be stuck where it becomes an obstacle. And the institutional barriers that are there to protect us from real danger, when they expand to protect us against the feared for layers of danger, you know, can create, you know, the trauma layers where, you know, like in the NICU, the moms who say things like, you know, I'm dangerous to my baby. When that isn't the case, when there are specific things we don't do to protect so that we can protect the baby, but that I myself as parent am not. I haven't ruined everything. I'm not going to ruin everything, because
Right.
that's what it can lead to if it runs amok. And that's what we're trying to prevent in ourselves and in the families that we see. So,
And I think part of it is just that sense of remembering that if we do the basics well, small things are not trivial, because the bottom line is to really help a person to move into a state of calmer, more regulated emotional awareness and within window of tolerance. The reality is people fear their own capacity at this stage, that their very thing that they should be able to trust their mind, their body, their relationship with the child, that's all going to be defective. And so the key thing at this point is by doing and taking back the basics of stabilization and psychoeducation, that these are the tools that have a huge effect. And Dr. Derek Farrell worked with the Yazidi women in northern Iraq. Part of the problem was in the camps, these women who'd been used as sex slaves for ISIL. Part of the difficulty was that, again, there wasn't always the ability to do a lot of reprocessing work. But what they've been able to show from the studies there is that there is a measurable treatment effect from stabilization work. And so we should always remember that that's really important, and not to sort of say, oh, I only got to do stabilization. That's very, very, very important. And at these points, it makes a difference between a parent being able to think and see that they are good enough instead of being stuck in the place of I'm worthless or I'm incapable.
absolutely.
And children need to know there are no perfect parents. I haven't met any. I certainly wasn't.
No.
No.
Thank God. I always tell people
We're all
thank
learning,
goodness.
so we don't want them to grow up thinking they have to be perfect. They need to know they're going to make mistakes.
True. And it's a good thing, because the world is not going to be perfect either. So, you know, they're going to be very disappointed when they walk outside if they expect that. Thank you. Thank you, Paul. Thank you, Katie. Thank you, Jamie. And thank you, Chuck, in the background, for keeping us running here. And thanks to all of you for coming. Thanks to all of you who are going to be listening to this recording. Welcome and thank you. And we hope to come back again. We hope you all stay safe and well. Keep doing your self-care. Take care of each other. And stay connected. Stay connected to each other and to us. Bye-bye.
To all